So we are there now with the slides. So the risk factors could be ocular or could be systemic, and these are some of the cases. This is after traditional eye medicine such as honey. This is post-LASIK keratitis. You can see a flap, and when inadvertently used topical steroids and this kind of thinning and perforation can occur. Then the symptoms are very easy to remember. RSVP, so redness, sensitivity to light which is increased, visual acuity which is decreased, pain, discharge. And if there's associated conjunctivitis, think of GPH. GPH is gonococci, pneumococci, and Haemophilus. The slit lamp examination, you have to see the area and the density of the infiltration, the size and depth of ulceration, the size of the epithelial defect, the degree of stromal edema, scleral involvement, and AC reaction, if any. And you have to look at not only the epithelial defect, which is this, but the stromal infiltrate also. So stromal infiltrate would be beyond the epithelial defect at every visit. And then you ask the patient to change the position, so the hypocure moves. You need to know what is the grade of the ulcer, which could be mild, moderate, or severe, because that determines what drugs you're going to start. So you remember 2 to 5, and more than 5. So depending on this, it could be mild, such as this, moderate, or severe, as is shown in these pictures. Sometimes the ulcer speaks, in the sense that you know which organism it is. So if you have a punched out lesion like this, the surrounding cornea is quite clear. It's most likely staph. But if you have a cornea which is edematous, the surrounding cornea is not clear at all, it is probably pneumococcus. On the other hand, the pseudomonas will have a classical greenish yellow discharge with a ring ulcer at 48 to 96 hours, descemetocele perforation which occurs within 2 to 5 days. Then sometimes you have atypical organisms such as this. So it's after mycobacteria, after trauma or indolent ulcers. Classically has this cracked windshield appearance. Notice the surrounding cornea is quite clear and there's hardly any AC reaction. The Moraxella ulcers, on the other hand, are inferior. They are oval. They are localized, such as this. And then you have the nocardia ulcers, which again have a wreath-like pattern or flower-like pattern. If you look at the ulcers, almost 3/4 of the time you can predict what organism it is, but for 1/4 of the time you still have to do microbiology. And microbiology is the mainstay for a case of microbial keratitis. So the scraping is done with the help of a 15-degree blade from the base of the ulcer and from the leading edge of the ulcer, and one can also do it with a modified Kimura spatula. I told you earlier also that the most important stain is KOH. Otherwise, we classically do gram stain, and acid fast is done for organisms man, that is mycobacteria, actinomyces, and nocardia. Then classically we culture on blood agar, on chocolate agar, and Sebro's dextrose agar. And if we are suspecting mycobacteria, then LJ media, and for Acanthamoeba, non-nutrient agar, E. coli. So everything which is associated with the infection goes in for cultures, whether it is a suture or it is contact lens solution, or contact lens case. And in at least twice negative smear and culture, no clinical improvement. You can even do corneal biopsy using a partial thickness trephination. The treatment strategies, like I told you, it is important to categorize these ulcers. If they are mild, less than 3 millimeters in size, not involving the visual axis, you will start monotherapy in the form of Gataflox or Moxiflox. But if they are moderate ulcers, more than 3 millimeters in size, involving the visual axis, you would start a combination therapy so that you cover for both the gram-positive cocci and the gram-negative bacilli, so lecafuzuline 5% with tobramycin 1.3%. So loading dose is given in the initial 48 hours, even during the time, even if the patient wakes up throughout the night. So it is given an hourly dose, and you assess the clinical response after 48 hours. Now, these were two randomized controlled studies which were done at our center, where we compared moxifloxacin as well as getafloxacin in combination therapy, and in more than 220 plus patients, and we found that in moderate ulcers, these two are equivalent to each other, and you can give monotherapy in cases of moderate ulcers. Adjunctive therapy continues in the form of cycloplegics, anti-glaucoma medications, and topical steroids. And systemic antibiotics are given in perforations, post-perforations, scleral involvement, and whenever the organisms are Neisseria or Haemophilus, which can penetrate an intact epithelium. Now, this was the steroids for corneal ulcer trial, the SCUT trial from the Madurai group. which taught us that topical steroids may be used in a case of bacterial keratitis, provided the loading dose of antibiotics have been given for 48 hours and culture and sensitivity report is in hand. And never start steroids if it is nocardia, atypical mycobacteria, or it is fungal keratitis. So you have to see the clinical response. If it is favorable by the AC reaction which decreases, the infiltration which decreases, there's epithelial healing, then you continue the medication. And if it is unfavorable, then you look for other organisms like herpes, fungus, and protozoa, and other factors like dry eye, vitamin A deficiency, or exposure. But if the ulcer is responding, and even if your culture sensitivity report says otherwise, change nothing about it. Continue with the same. Then specific antibiotics are for specific organisms such as vancomycin for MRSA or methicillin resistant staph, ceftazidime for severe Pseudomonas keratitis, amikacin for Mycobacterium fortitum kiloni and nocardia keratitis, along with the systemic agents. And of course, if the bacterial keratitis is not responding, then topical colistin, imipenem can also be started. Now, the second type of keratitis that I would be talking to you is the fungal keratitis, which has got a seasonal variation and which in our country makes a lot of sense because almost half our cases are because of this. And this I already highlighted to you that aspergillus is more common in North and West India. Fusarium is more common in South and East India. So you will have dry, thick, raised texture with feathery margins, satellite lesions, endothelial plaques, and fixed hypopyon. And sometimes you will have brownish pigmentation like this. So this is not iris prolapse. This is brownish pigmentation of a dementitious fungus. And when you treat it, the pigment, it disappears. Of course, Fusarium will have a very severe course and yeast has a collar button configuration. Then again, if you've diagnosed fungal keratitis on 10% KOH, we'll start antifungal therapy, culture it on Sebrot's dextrose agar. And there are other modalities as well. Suppose a culture doesn't show or the smear doesn't show fungus and you think clinically it looks like fungus, you can still pick up these fungus on confocal microscopy and also monitor these ulcers on anterior segment OCT, especially if it's a posterior abscess. This will also monitor your treatment, whether the ulcer is responding or not. So the mainstay for a case of fungal keratitis is 5% netamycin, and if there's worsening, you either add amphotericin B or 1% voriconazole, and the therapy lasts for 4 weeks. So this is a case which is healed on topical netamycin. Of course, the currently available antifungal agents have poor ocular penetration, poor bioavailability, as well as toxicity. And the MUT1 trial showed us that voriconazole should not be used as monotherapy in cases of filamentous keratitis. You can give systemic antifungals when the ulcers are large in severe deep keratitis, when it is associated with endophthalmitis or after penetrating keratoplasty. And the drugs that we like to give are ketoconazole 200 milligram BD or voriconazole 200 milligram BD. And generally, you have to do liver function tests every 2 weeks. Now, this is a classical case which healed on topical netamycin and systemic ketoconazole, the case of Fusarium keratitis. And this is yet another case which was a tunnel fungal infection which healed on topical voriconazole and systemic voriconazole. The MUD2 trial again by the Arvind group did show us that Fusarium keratitis may benefit from addition of oral voriconazole to topical netamycin. And we compared oral voriconazole with oral ketoconazole, and we found that the infiltrates, there was no difference in the resolution of infiltrates as far as the time was concerned, but we looked at the tear film and the serum concentrations, and we found that the penetration of voriconazole in tear film was significantly better than ketoconazole. So if the patient can afford it, start voriconazole. If the patient can't afford it, continue with ketoconazole. Now, because these topical medications cannot penetrate, there are other routes by which you can give these drugs. One is the intracameral antifungals, not responsive to medical therapy, thick hypopyon, endothelial exudates, and deep anterior chamber exudates. So you can give either amphotericin B, 5 to 7.5 microgram per 0.1 ml, or voriconazole, 50 to 100 microgram per 0.1 ml. And this is a large hypopyon which resolved on intracameral amphotericin B. You can also give intrastromal injections for non-perforated ulcers, and if they're not responding to your classical antifungal therapy for 4 weeks. Now, this was a case, the very first case in 2006, which was to go for therapeutic keratoplasty, and we thought, let's give intrastromal injections. and it resolved with intrastromal voriconazole. So since then, we published three of these cases in American Journal of Ophthalmology, and also a randomized control trial. And we've started giving intrastromal voriconazole in cases of fungal keratitis since 2006. Now, this study helped us to get to a conclusion that when you add topical voriconazole to topical netamycin, then the healing response is faster. So these are two sets of cases which healed on topical netamycin and voriconazole, and these are two sets of cases which healed on topical netamycin and intrastromal voriconazole. So this is the method by which you give these intrastromal injections, and these are the lesions. So you go and surround this lesion with the intrastromal voriconazole. This is a 30 gauge needle which is being used. So you surround it in 4 to 5 hemimeridians with a bevel down, and the reflex is very much like the reflex that you get in a phaco wound. So 5 to 6 injections are given, and if required, you can repeat after 72 hours, and 3 or 4 such injections can be given. Of course, your topical medications will continue with this therapy. But this is just to show a combined intracameral and intrastromal voriconazole. So wash up the exudates first, inject intracameral voriconazole, followed again by the intrastromal voriconazole, which is given in 5 to 6 hemimeridians surrounding the lesion, very much like the way you do a macular grid or macular barrage for macular edema. And the idea is that for that particular period of time, it's like a bolus dose which is going there. This is what we published, the TST protocol for fungal keratitis, the topical, systemic, and targeted therapy. So if the ulcer size is less than 5 millimeters in size, less than 15% of the stroma, you start with the topical netamycin. If there is no response, then you add amphotericin B or topical voriconazole. However, if the ulcer size is large, then you start topical and systemic. And if there is no response, you add topical voriconazole to it. And if there's no response for 4 weeks, then you give a targeted therapy in the form of intracameral, intrastromal, or both, depending upon where your exudates are. And this was based on a prospective study of over 223 patients, which we looked at, and the success rate is to the tune of 80%. For intrastromal group, when it was added, it increased to 89%. So this is the publication thereof. Now, what we are also working at is to make the netamycin soluble. So this netamycin normally comes as a suspension like this. We've linked it to polymer in our ocular pharmacology lab. It's become soluble like this. So the penetration is far good, which is also seen in the pharmacokinetic studies. And this is a case of fusarium, post-LASIK fusarium keratitis, where we gave intrastromal netasol, and this has responded to therapy. And then at a later date, you can always do a penetrating keratoplasty for this. And sometimes it is a multi-pronged attack. So sometimes for infections, you have to do therapeutic keratoplasty, and then there's a recurrence, and then you can give intrastromal injections, and then they heal on therapy. Now, coming to this last bit, which is viral keratitis, herpetic eye disease and non-herpetic eye disease, as well as adenoviral. So it could be herpes simplex keratitis, which could be epithelial like this, or it could be stromal, such as like this, or it could be endothelitis, such as like this. Then epithelial dendrites are the way they look like this. Always stain them, because if you don't stain them, then sometimes you can miss them, and you don't know what is happening, although the patient is complaining of pain and redness and watering. And if the patient has used steroids, in a case of dendritic keratitis, then it breaks down to form geographical ulcers. So if you have a picture of geographical ulcer, always ask the patient, are you using topical steroids? And 99% of the times, he or she would be, and then the only thing you need to do is stop steroids. So then you can have stromal keratitis, which could be necrotizing, or immune stromal keratitis, such as double ring of Wesley. Then these are again examples of stromal keratitis. Then necrotizing stromal keratitis, which is so devastating that it causes thinning, perforation, and vascularization. Then only the endothelium may be involved, such as this disciform endothelitis, linear endothelitis, or diffuse endothelitis, or even herpetic marginal keratitis. Then you can have neurotrophic keratopathy if it is recalcitrant, especially the herpes. And the mainstay, I think this is the single most slide which is important for the treatment protocol. So if it is epithelial herpes keratitis, you start acyclovir 5 times for 1 week and then taper 3 times for 21 days. If it is epithelial and stromal, treat the epithelial first. So you will start only topical acyclovir. And after 1 week, you would start with the prednisolone acetate to treat the stromal and then taper both by 6 to 8 weeks. However, if it is necrotizing and non-necrotizing, then to the therapy that you started, you will also add systemic acyclovir 400 milligram 5 times a day for 1 week and then 3 times for 1 week. Then oral acyclovir, like I said, has to be started even when you're doing grafts, so you prevent recurrences. Ganciclovir is another alternative which can be given, especially those cases which are acyclovir resistant. Valcyclovir can be given instead of systemic acyclovir because the dosing is less frequent. And then if it is a metaherpetic keratitis, then you may have to give lubricants or do conjunctival flaps or amniotic membrane grafts or glue for perforations or even patch grafts or tectonic grafts. So I think we can. No, it's okay. So this is just to show how you would do a amniotic membrane. So a small patch of amniotic membrane is put always in a case of neurotrophic ulcer, followed by a larger patch which can be either sutured or it can be glued. Then you have another entity which is zoster keratitis, which is very much like simplex, except that you have vesicles on the face like this, and you have microdendritic ulcers, nummular keratitis, or disciform keratitis. Sometimes you even have mucus plaques, and this is how you distinguish between the two. The herpes simplex has a excavated appearance, dendrite look, whereas the zoster would have a more painted look on it, and it will stain the herpes simplex, whereas with zoster there would hardly be any staining. Of course, the treatment part, you have to remember that in zoster the dose is double. So it is 800 milligram 5 times a day for 10 to 14 days. There is no role of topical acyclovir in varicella zoster keratitis. And there's a vaccine which has come for prevention, which is very much used in the West, not so much used in India. And this is the adenoviral keratoconjunctivitis that we were talking about. So if it is in the visual axis like this, so many of them, then you would start topical steroids. And if there are recurrences, then add topical cyclosporin to it. Otherwise, like I said, central and vision threatening, topical steroids for 6 weeks. Then you can even give tacrolimus as we were discussing. And of course, the surgical treatment, if there's impending perforation, if there is small perforation, then you will probably do a glue. So just put a cyanoacrylate glue there and a drape there, and then this is followed by a bandage contact lens, and this would heal over a period of time. So this is a large perforation which is healed on glue. Then if it is a desmetocele such as this, then you can do a deep anterior lamellar keratoplasty for these cases. So this is a small desmetocele which is there. So this is opened up like a keyhole, and these layers would come off very, very easily. I'm sure Susan has done numerous of these. And then you can do a full thickness donor cornea. You can take these layers are just waiting to come off. You can peel them off very easily. It is very simple to do DALC in case of desmetoceles, unlike in case of keratoconus or other cases, because this is pathological. It is so this is still extraocular, and the clear Descemet's membrane is looking at you, and over this you can place a graft. So this is how it looks in the post-op picture. And of course, if this is an infection like this with impending perforation, then you have to do a therapeutic keratoplasty for this. And this is a ulcer post epileptic keratitis due to pseudomonas, which is not healing at all. So you take a large graft and encompass about 0.5 to 1 millimeters the clear area, remove all the exudates, give wash appropriately with the antifungals or antibacterials, which could be voriconazole or vancomycin. And in this case, it was pseudomonas infection. So we washed with vancomycin followed by a large graft, which can be done. And this is a case where later on you can do a optical penetrating keratoplasty. So if you want to know the details of therapeutic grafts, we've written two articles, one on current opinions of ophthalmology and the other in survey of ophthalmology, the details of which are very much there. And this should be the healing of the ulcer over a period of time. Stain every time that the ulcer comes so that it becomes a faint scar and not like this, a case of infectious crystalline keratopathy after LASIK with thinning, with perforation. We could not diagnose it. It was due to alternaria and finally had to undergo a penetrating keratoplasty. So this is our book on corneal ulcers. We are coming out with the second edition very soon. And thank you for your kind attention. Okay, so pythium keratitis is truly a nightmare for any any corneal person who's treating it. So linezolid is the drug which has been advocated for it, topical linezolid, which came from LVPI, and you can use that drug. People have even tried azoles on it, and for systemic ichthyosis, they are even using triple vaccine. So the patient that we treated, and finally we lost the patient because the patient had endophthalmitis, panophthalmitis, cavernous sinus thrombosis. We also treated with systemically with the vaccine. So this vaccine is not available here. It comes from Singapore. It has to be imported from Singapore. So you can even give that. As far as the penetrating keratoplasty is concerned, you should rush to do a penetrating keratoplasty. The earlier you do, the better, because it spreads very fast. Whenever you have guttering of the lesions, then you should suspect pythium keratitis. It is classically present with a gutter and with a reticulated margin like that. So these are the two things you would suggest as pythium, and immediately rush. If you look at the literature, almost 80% of the cases that have had to go undergo a penetrating keratoplasty for pythium keratitis. So it is earlier, very early rather than later, especially if you have a diagnosis. That is the only way to save the.
Thank you, ma'am. We had one online question. What is the preferred practice which you follow in a case of acanthamoeba keratitis?
So acanthamoeba I did not cover because, but what we would do would be a combination therapy. So we would start with PHMB as well as with the propamidine eye drops, both of them together. And we would give it again for a prolonged period of time, classically at least for 3 to 6 months, if the ulcer responds and heals. And sometimes even systemic drugs can be started like itraconazole. People have even used voriconazole for acanthamoeba, but I think the ideal would be PHMB and diamidines.
If you're sitting in a primary center, a primary or secondary with no access to any culture, so when do I actually start referring an ulcer to a tertiary care for the scraping?
So if you're sitting in a primary center, then the important thing is, I think you can all make smear. KOH doesn't require anything. If you have a laboratory microscope with you, that would be ideal. So if you have a KOH, you can start your antifungals immediately. Otherwise, you would start your antibacterials. And if the ulcer is not responding within, say, 7 to 8 days, I think it is best to refer.
Postgrads, any questions? You guys have not asked nothing yet.
Yeah.
No questions?
Yeah.
For everything?
Aisha has a question.
What's the role of steroid in this bacterial keratitis?
Pythium keratitis.
Pythium or bacterial
keratitis? So, like I said, bacterial keratitis, if you have a culture report in hand, and if you've already loaded the organism, already loaded the ulcer for 48 hours, you can start topical steroids. I'm less conservative about topical steroids than others are, because you don't want that thing to scar. After the ulcer starts healing, you want the cornea to get clear as fast as possible. So if it is not mycobacteria, if it is not nocardia, it is not fungus, I would start topical steroids after 48 hours of antibiotics. Also, it is shown in the SCUT trial only that pseudomonas ulcers, they do better with topical steroids. The best corrected visual acuity was, better in those cases where topical steroids were started. So I would, start earlier than later, provided these organisms are not there.
There's a question about how they mix injection voriconazole and how much intrastomal to be given.
So we would give about 0.2 ml of the intrastomal drug, 50 to 100 micrograms per 0.1 ml, and the how much to mix. I do have a slide. Are we on this thing?
We can connect it. Huh?
Yeah, connect.
Yes, ma'am. You can put this slide.
So we do have it used to come as a lyophilized powder, And then we used to mix the lyophilized powder with the, you can dilute it in the teardrops, or you can even dilute it in the, you can even dilute it with the BSS to make those intrastromal injections.
Do you give routinely, ma'am, intrastromal injections? What's your take on intrastromal antibiotics?
So I gave routinely intrastromal injections. I think they have to be given earlier than later. I mean, you don't have to give them when you're taking a case for therapeutic penetrating keratoplasty, but you have to give it when when the ulcer is not perforated. If it is more posterior in location, because you know the natamycin is not going to penetrate that well, or natamycin and voriconazole are not acting, and more for posterior abscess than for anterior abscess. But if it is not responding, and with the hypopion, I would go in for a combined intracameral and intrastromal injection.
I think Konya consultants wanted to know about the success rate following intrastromal antibiotics.
So like I said, the overall success rate in our series was almost 80%, and it was 70% when we didn't give the intrastromal injections. It increased by 10% more when we gave the intrastromal injections. But we followed that protocol, and see, the problem was that the studies that were done, the MUT1 study told us that don't use topical voriconazole as a monotherapy. Then MUT2 told that don't use systemic, it doesn't work. Then the Mellon study told that intrastromal injections don't work. Then this cross-linking study told us that cross-linking doesn't work. Then what works? I mean, you can't do just natamycin and organ transplantation. There is a series of whole spectrum of cases which are mild, moderate, and severe, and you have to do something about them if natamycin doesn't work. So that is why this protocol that we devised, so that at every stage you know what works. And if you do a corneal transplantation, like I said, the story starts from there. It's a graft. There are suture-related problems, recurrence of infection. It's an open sky procedure. So all those kind of graft rejection, all those kind of problems would start after the graft is done. So that's another completely new chapter. So you don't want that to happen.
We have another online question. Let's take that. If it is an epithelial with stromal involvement along with the keratouveitis due to herpes, how do you proceed in such cases?
So we would do, for the epithelial keratitis, we would start topical acyclovir, and then after maybe, classically it is taught that after 7 days you start topical steroids so that you take care of the stromal as well, and also systemic acyclovir, because systemic works for keratouveitis. So I would start topical acyclovir for a few days and then immediately shift to steroids.
How long do they have to be on systemic antivirals, ma'am?
So systemic antivirals classically are given for 3 to 4 weeks, provided the ulcer is responding. In cases if you've done a penetrating keratoplasty for viral keratitis, then prophylactically to prevent a recurrence, you have to give 400 milligrams acyclovir twice a day for at least 1 year after the graft.
What is your take on povidone for adenoviral conjunctivitis?
So there is a study which compared povidone iodine for adenoviral. That is the only study which showed that there was a beneficial role, and I don't think it works that, the treatment, I mean, the results are not that dramatic, and patients are quite uncomfortable and they can't see, and it's getting hazy each day. So I don't think povidone iodine as a standalone will make a difference in case of adenoviral keratoconjunctivitis.
In the endogenous infection, sometimes it presents only as an endothelial abscess. So how do you go about treating these cases apart from your systemic antibiotics? So topically or intrastromal, or is it intracameral?
So if it's a fungal one, then you can do intracameral and intrastromal both, apart from the systemic antifungal agents also.
One more online question. What's your take on scraping, debriding, and epithelial removal for better medical response, ma'am?
Okay, so again, the MUT1 showed us, the preliminary study that they did, they showed us that there's no role of debridement, and yet all of us are doing debridement because That increases the penetration. It causes, when you're debriding the ulcer, you're debulking the ulcer, so it takes off quite a bit of load from the microbial load from the ulcer itself. So I do feel, even though the study showed that there was no role, it does have a role to play, both in fungal keratitis and even for acanthamoeba. If you just debride a little bit, it does help.
And the role.
So lubricants in a microbial keratitis, I think, is a no-no, because for the simple reason, you're trying to give concentrated drugs and the patient is already tearing because of the ulcer, and if you add lubricants to it, then you are diluting your concentration of the drugs. So it is best to avoid them unless if it is a case of dry eye which has had a corneal ulcer, then in those cases you might think, but there is no point diluting your concentration of antibiotics or antifungals.
How do you treat neurotrophic keratitis? So difficult to manage. Recurrences keep coming.
So neurotrophic keratitis, the active one, we would again give plenty of lubricants. Sometimes you may even have to do amniotic membrane transplantation. If you don't have access to amniotic membrane, then you can just do a tarsorrhaphy. Or in those cases, sometimes people even have done flaps, conjunctival flaps for neurotrophic ulcers. And when there are chronic neurotrophic ulcers, I last week attended a workshop on corneal neurotization. So what they do is that they take the sural nerve from the calf and they place it in the orbit, and then finally those vesicles are vesicles are split, and these corneal the vesicles are then made to come through the limbus so that they innervate the cornea. So it appears to be a promising technique, but very few cases have been done in the world. The Toronto group from Canada is doing it. There is a new drug as well which helps, but it is extremely expensive and not available in India as of now. So cross-linking for fungal keratitis doesn't work. We published a study and so did Arvind. They had to stop the study midway. See, the problem with the cross-linking in fungal keratitis is the cross-linking protocol that we're using is for keratoconus. Now that is a normal cornea, or a keratoconic cornea, and it doesn't translate very well into a cornea which is, affected by has keratolysis or affected by the microbes. So I think it's an overkill for whatever protocol we are doing. For bacterial keratitis, it is shown to have good results, but for fungal keratitis, it doesn't work. And of course, herpes you should not do because it will trigger a...
At what stage do you intervene with cross-linking for a bacteria?
If it is not responding to topical medications and systemic medications, you can, but again, for ulcers which are earlier, mild or moderate ulcers, you may do it if they are not responding to it.
What's the protocol that you use for this?
Generally, people use Dustin protocol. So I think they have to make protocols for microbial keratitis. It can't, you cannot use the same UV radiation and the same this thing that you use for a normal cornea.
Ma'am, this raging issue of antimicrobial resistance. So what do you prefer when you see a non-contact lens wearer with a corneal ulcer presenting to you with probably a secondary center with a 1 millimeter, 2 millimeter involvement of the corneal ulcer? What should we start? The first line antibiotics in the sense.
The first line would be a fluoroquinolone or combination therapy. And if it's not, like I always said, it is very important to know, like a tertiary care center like such as yours, patient would be, multiple drugs already somebody would have given them a cocktail therapy of antivirals, antifungals, antibacterials. So there are two things which are important. And whenever there's a confusion and it's recalcitrant and it's not healing, just stop everything for 24 hours, except for lubricants and cycloplegics, and re-scrape, because you don't know what the microbe is. And if you start everything together, you don't know what you're already over with, or what, even if it is responding, you don't know what it is responding to. So you need to get your, mathematics right. So you begin with antibacterial. If you have anywhere in microbiology or Confuscan fungus, add antifungal to it. Even with antifungal, we give antibacterial always for the reason that you don't want a super added bacterial infection. And then if it's not responding to both, then you should know what the patient already, if the patient, like I said earlier, is already over with combination therapy, then you know it's not working. And you know the patient is putting the drops, the compliance is there. You would go in for fluoroquinolones or higher antibiotics. Sometimes you've had to give colistin or meropenem eye drops you've had to make because the patient was resistant to all the other drugs. That's why vancomycin we don't use much, because you don't want resistance against vancomycin. That's the last stage, 5% vancomycin that you might use. That we kept as a reserve drug so that resistance does not develop to vancomycin.
So what would be the best empirical therapy in a wound-related corneal ulcer?
So wound-related, I understand.
Wound-related.
So again, you would, which means it's a tunnel infection or which means it's a side port infection. So we would go in for topical. If that doesn't heal, you would debride de-roof the area where the wound was and touch it with the betadine. Again, give topical. And if it doesn't work out, then maybe you have to give intrastomal agents.
And in case of an outdoor trauma, what would be the empirical choice?
Again, it would be the same.
Household dust related. People always have a history of something,
fell into the eye.
And, yeah.
So I think something fell into the eye, and then there are things like this. If it's vegetable matter, it is fungal keratitis. It's not so. If it's vegetable matter, you can get bacterial also. Although you would tend to think that more likely it is fungus. So those kind of myths are there, but I think it is best not to generalize them. Although you would think in that direction.
Gatti or moxi?
We have one more, gatifloxacin and moxifloxacin.
Gatifloxacin, I would say. I mean, this is again personal and not anecdotal.
Okay.
For the simple reason that gatifloxacin, most of them have benzalkonium. So I feel that benzalkonium also acts as an antibacterial agent. Moxifloxacin is preservative-free. So there's no additional benzalkonium, which is, has antimicrobial. Benzalkonium has good antimicrobial properties. So for corneal ulcers, it will be gatifloxacin.
0.5%.
For prophylaxis of cataract surgery, it will be moxifloxacin.
Ma'am, I have 3 questions.
You have a bright set of students. All of them have good.
Sometimes the patient comes back with a block and it changes color. From transparent, it becomes like light yellow.
Yeah.
Does that mean we have to replace?
They have to replace it. Yeah.
Now, my second question is like fighting cases we started taking away. So it comes in that diet, and then we actually dispose it in those small
Yellow curds.
So can we use the same whole thing, or do we have to, like, once it's open, we have to?
No, once it is open, then you have to put it into those. Put it in the beginning only, rather than. Yeah. Yeah.
Third question, ma'am, what is your Pseudomonas keratitis?
So for severe Pseudomonas keratitis, it is ceftazidime, but it depends on what the cultures are at your place. For us at RP Center, it responds very well. It is quite sensitive to polymyxin D also.
Monotherapy topical, you were talking about moxifloxacin versus gatifloxacin. Would you prefer 0.3% or 0.5?
0.5, both.
Excuse me, what is the role of long-term antibiotics?
So antiviral prophylaxis you give whenever there are recurrences, and if you have more than 3 recurrences in a year, then it has a role to play. And recurrences, also you would give prophylaxis of antiviral when you're doing a penetrating keratoplasty in a case of viral keratitis, because you don't want the recurrence to occur. So the dose curative would be 400 milligram 5 times a day, but for prophylaxis it is 400 milligram 2 times a day. For at least 6 months, sometimes even up to a year.
Any role of tobramycin, ma'am? One of the online questions.
So tobramycin, we do give concentrated cefazolin and tobramycin when you're treating a case of bacterial keratitis, which is more than 3 millimeters in size and which involves the visual axis.
So I'm sure ma'am has cleared all the air.
No, I have not. I have not.
So we have patients who we treated for adenovirus and meningitis spread, and then they've been put on steroids multiple times, and then they come back to us. So when they come and they see multiple nodular lesions right in the visual axis, and so how do you treat them? We've already gone through the entire phase of steroids, tapering multiple times, and the lesions are not active. They start.
So you start topical steroids. You tell them that you will follow up with me only because I need to taper the steroids and I need to know that don't stop. The most important thing is as soon as they start topical steroids and everything clears up, they stop it immediately. So we'll start topical steroids full on, like a pred phosphate or a pred acetate, QID. Sometimes I've started 4 hourly, sometimes even 2 hourly if there are too many of them. So you start it along with topical cyclosporin or with tacrolimus. So it has to be coupled. And then taper topical steroids over a 6 weeks period, and your restasis or tacrolimus still continues for at least 3 to 6 months. You have to just pep up your steroids. Then I would give an ointment also at bedtime, topical steroid. That is the only way those things are going to go. Otherwise, they'll scar permanently. The patient loses BCVA, best corrected visual acuity, and you don't want that to happen.
If I'm seeing a patient like this, maybe after a year and it's scarred now,
Adenoviral, you have to be a little careful about PTK because it will again cause, resurgence of adenoviral adenovirus, because it tends to stay there. So I think PTK has no role, but if the best corrected visual acuity, is say is about 636 or 660 or something like that, you may have to do a corneal procedure for that. Depending upon, get a ASOCT done and see what the level is and ask Susan to do a SALC, superficial anterior lamellar keratoplasty.
I think that's it for now. So the environmentalists may differ regarding the AQI, but I think we at Agarwal for sure know that ma'am has definitely cleared the air on microbial keratitis. Thank you so much for that, ma'am.
And thank you for having me here. It's a complete pleasure. And I never expected so many questions.
I want to say one thing. Hats off to Namrata and no other question.
Thank you so much. Thank you so much.